So thank you very much for inviting me. I'm very excited to be here in this very interesting part of the world. And Professor Dimopoulos was supposed to give this talk. He was kind enough to give me his so that I could do this. But the myeloma world is changing significantly, and somebody needs to tell me exactly how to move the slides. How do I do this? How? Thank you. So, sorry, thank you very much. No. I just want to advance the slides. Yeah. Where is that? Yeah. Okay. So, sorry, thank you very much. Obviously, the data for multiple myeloma is different in different parts of the world, but this is just a short summary of the latest available data on the incidence of multiple myeloma in the United States. And as you can see here, it is the 14th most common disease. Having said that, it represents a disproportionate burden on the healthcare system because of the chronicity of the disease. In contrast to when I first started in the myeloma world, where the incidence of multiple myeloma was about 12,000 per year in the United States, and the mortality rate was about 11,000. Now the incidence is almost twice as high, and yet the year-by-year mortality has remained the same, a reflection of the enormous advances we've made in the management of multiple myeloma. All right. The presenting features of multiple myeloma, I'm sure you're aware. Having said that, with the improvements in diagnostics that are available today, many patients with multiple myeloma present without any clear presenting features as their presenting complaint, although the many manifestations of myeloma remain the same. So, having prefaced the talk with something of the numbers of patients that we deal with, the reality of it is that we remain very unclear as to which patients should be called multiple myeloma and which patients, more importantly, should be treated for their multiple myeloma. So this is the latest version of the NCCN guidelines, which are the federally published statutes for the criteria for multiple myeloma. Now, we use many different staging criteria and diagnostic criteria, but these are the official ones in the United States. So we distinguish smoldering myeloma from multiple myeloma in the past based on whether these patients are symptomatic based on a set of criteria that we called CRHM criteria. Having said that, in the last 2 years, we've changed those CRHM criteria to include a number of other variables which we now call SLIM CRHM criteria. So in addition to those that you're all familiar, hypercalcemia and renal insufficiency, anemia and bone disease, we now have 3 additional criteria. And those include extensive marroplasmacytosis, greater than 60%, light chain ratios of involved over uninvolved of more than 100, and more than one focal lesion on a total skeletal MRI. Now, this is a little bit confusing because we all have patients who met those criteria previously, but who we were not treating. So now we have this sort of dubious situation in which we have patients that have all of a sudden changed from an asymptomatic disease that did not warrant intervention to a process that that treatment is now justified. So again, these criteria we now call SLIM CRAB. So we continue to have 3 separate subsets of patients, 2 of which don't require treatment and 1 of which does. So the MGUS criteria has remained the same. There's been no changes. The smoldering myeloma criteria remains the same, except that the highest risk smoldering myeloma patients have now been shifted into the multiple myeloma category. So we now have a category that we call myeloma requiring treatment. Now, I object to that definition. I think it should be called myeloma in which treatment is justified rather than myeloma requiring treatment, because I certainly think that those patients who have established that they have a stable process, even though they meet that criteria, that treatment should not be instituted until there's some evidence of progression of disease. Having said that, the current criteria are CRAB criteria plus the new criteria that I had stated. That's abnormalities that are either radiographic or serologic. So if we take the smoldering myeloma population, we can break them down into a set of patients who are more likely to evolve into symptomatic myeloma, and those less likely to evolve. So those with bone marrow plasmacytosis of greater than 10%, those with serum M spikes of greater than 3 grams, and those with free capital lambda ratios with between 0.125 and greater than 8. And as you can see here, the patients who have all of these criteria are extremely likely to progress to symptomatic myeloma. Those with one criteria, with greater than 1 criteria, and those with 1 criteria in terms of that. And I think that we all need to be very aware of the different stratifications rather than lumping these into one group, particularly in terms of how we monitor those patients. So the staging guidelines for multiple myeloma have also changed of late. So everybody has gotten used to using the ISS staging criteria, and I apologize if this is a little bit small and difficult to see, but these criteria were very easy. We just needed to know the beta-2 microglobulin and the albumin of those patients, and we had a fairly reliable mechanism for predicting the likelihood of these patients to go on to successful treatment outcomes versus those likely to relapse. But we all understood, even when we were using that ISS staging criteria, that there were molecular and biochemical overlays that were very, very important in terms of identifying patients who were going to have bad outcomes. And we basically ignored that in our standard staging criteria. So now we have an effort to include both biochemical parameters, and that is high LDH, and genetic markers of tumor instability, and that's things such as the gene expression profiles that have become wider and wider in terms of their utilization, and standard genetic markers such as FISH. So we now have a revised ISS staging system. You should note that there are patients that would have been characterized as having ISS stage 3 disease that in this newer staging system will be downgraded to stage 2. So it's again a little bit confusing, and then those are patients who have high beta-2 microglobulins but do not have high LDH levels, and those patients will now be called stage 2 by ISS. The Dury-Salmon staging system that you see here is still in widespread use. We still all stage our patients by Dury-Salmon, but it has relatively little bearing in terms of clinical outcome in today's world. It was a staging system that was largely oriented towards tumor burden. And in an era where we had no effective therapies, tumor burden was the best predictor of both long-term and short-term outcome. So probably less useful in today's world. So there are a number of groups that have attempted to subdivide their patients based on molecular characterizations, and certainly the best known of those systems is the Mayo Clinic MSMART system that has been updated a number of times. The most recent iteration of this is the MSMART2 that you see here, and this uses that molecular characterization that we've been speaking about to substratify the patients. So you can see here that deletion 17p, 1416, 1420 are the standard FISH and cytogenetic markers. There are a number of gene expression profile systems. The two best known are the SKY from HOVON and the GEP70 score from the University of Arkansas, both of which are very effective in terms of predicting outcome for patients with myeloma. Of note, the 414 translocations, which used to be in the high-risk group according to the MSMART, now have been moved to the intermediate risk. And perhaps because of the more widespread use of bortezomib and its impact on that particular subset of patients. Well, let's get to the point of the conversation. So we need to make decisions about treating patients with multiple myeloma. And one of the very important justifications for treating patients is based on the skeletal involvement, as you can see here from this modification of the NCCN guidelines. So you can see that the presence of bone lesions and the presence of focal lesions on MRI are now part of the characterization of patients that would justify going on to treat them. So how do we most appropriately evaluate a patient's skeleton in terms of making decisions about myeloma? Well, we've for decades used skeletal surveys or whole body radiography to identify the presence of lytic lesions. And the point of this relatively old figure right here is that the blue lines here represent the identification of lesions by skeletal survey. The red lines represent the identification of skeletal lesions using CT as the detective modality. And I think the point that should be made here is that there are two things. This is a false positive right there, a patient in which a skeletal lesion was identified by skeletal survey. And I think you probably have all had the experience of sending a patient for a skeletal survey, writing on the request slip that the patient had myeloma, and getting back from the radiologist the presence of lytic lesions. I think that if we had not told the radiologist that this patient had myeloma, the radiologist would have probably chosen not to identify those lesions. But the point being is that, that there is a significant number of false positives in patients with whole body radiography. The other thing that you see here is that there are a number of lesions that are picked up by CT scan that are not picked up by whole body radiography. So what does this look like? This is what we see. We see lesions that were not apparent on the standard radiography that are easily picked up by CT scan. Sorry? Thank you. this is particularly relevant in the spine where whole body radiography is both insensitive and most prone to giving false positives. So very significant advantage to CT radiography in those areas. And I don't know how easy it is to see, but there are many subtle lesions that can be picked up and more diffuse lesions that can be picked up by CT that would not normally be picked up by a skeletal survey. The other thing that you can identify with whole body CT is the presence of extraosseous disease, and skeletal surveys are notoriously ineffective in terms of identifying those lesions, with the rare exception of those in the chest cavity, which can occasionally be picked up. But certainly this is one of the very important advantages. So there's been a number of studies that have been done. Bottom line is that in almost all of these studies, the increased sensitivity and the increased specificity of whole body CT over skeletal surveys has been substantiated. So here in slightly more detail, you can see the number of lesions. This is the total, the number of lesions that were picked up by whole body low dose CT scan versus whole body X-ray. So this is not a subtle difference. This is a fourfold increase in the sensitivity of CT imaging over whole body X-ray as a modality. So again, as we make decisions to treat our patients, this is critical, particularly since we're taking a population of patients that we're calling asymptomatic and making assumptions about the nature of their disease. So in a patient in whom there are other obvious parameters that dictate the institution of therapy, the use of whole body CT may be superfluous to some extent. But the reality of it is we have a large population of asymptomatic myeloma patients, and the role of whole body CT needs to be more clearly delineated. So Dr. Demopoulos and Dr. Terpos in Athens have done a study in which they took 80 asymptomatic patients with myeloma and subjected them to both whole body low dose CT and whole body X-ray, and what they identified was 13 patients, 16% of those patients had an identifiable lesion by CT. So these are patients who would have otherwise not been treated. So it is time that we realize that whole body CT has or should replace skeletal survey as the standard imaging modality. It is both sensitive and specific and identifies patients with focal disease that sometimes needs intervention. So this is the recommendation that has been put before the IMWG, and that is that whole body low dose CT should be considered the standard of care. So now we have other modalities that are being evaluated in myeloma. MRI has advantages and disadvantages. Obviously, MRIs are more difficult on the patient. They're much more time-consuming. They're more expensive to do. But MRI does have a number of advantages over other forms of radiography in terms of looking at myeloma. Now, there's many different techniques. I think that the standard of care has been T2 or stir-weighted image, T2 weighted or stir imaging, and you can see the difference in the visualization of these patients using different kinds of technologies. So here is a comparison of MRIs on a number of patients versus skeletal surveys. You can see what is obvious here, and that is that these lesions are not at all apparent on standard radiography. So again, the extraordinary sensitivity, particularly on focal bone marrow disease, not with extraosseous extension or extension through the cortical bone. So again, a comparison between T1 weighted imaging, in which the myelomatous lesions appear dull, STIR imaging, in which the myelomatous lesions appear bright, and T1 weighted imaging with contrast, in which the lesions again can appear bright. And to compare that lesion with CT, there is some subtle evidence of destruction, but in standard review of a CT scan, this is the kind of lesion that could easily be missed. So there are certainly advantages. Now, one of the problems with CT, with MRI, is that there's no standardization. And so diffusion-weighted imaging is perhaps a way to do this. Now, this is technologically relatively straightforward. Having said that, most radiologists have not started to incorporate this kind of evaluation. And you can see that there's important problems in terms of applying this kind of technology, because as we get older and our bone marrow becomes more fatty, the diffusion-weighted imaging changes, and in a young patient, the signal is much more profound than it is in an older patient. So as we look at MRIs, we need to appreciate that this is against a changing background. So here is a focal MRI in a patient with a 55-year-old patient with diffuse marrow involvement, but with a focal lesion. Here is the diffusion-weighted imaging, in which that local disease is quite obvious. Now we have to convert that into a standard value that can potentially be used as we do larger scale analysis and studies of this kind of imaging. So again, this is a patient with more diffuse involvement. This is the diffusion-weighted imaging, and so this patient with diffuse myelomatous involvement has a very high signal on diffusion-weighted imaging. So here's a younger patient, and something that is particularly relevant in this part of the world, where so many of the patients are younger than those that we see in the United States. The problem with that is that the background is also substantially higher. And you can see that in this comparison of a younger patient and an older patient. And here, again, a patient with a much more diffuse pattern of infiltration. So this is what this can yield. We can look at the standard kind of evaluation. This can be now digitized and quantified, rather than subjectively in the way most radiologists would look at this kind of data. Having noted that, there are very, very few institutions who are doing this kind of analysis. So. One of the other things that we should understand is that the pattern of involvement in the bone marrow is different from patient to patient, and there is a variegated or diffuse pattern as opposed to a focal pattern that correlates with the degree of marrow involvement when pathological specimens are obtained. MRIs are also very useful for distinguishing myelomatous involvement with subsequent fracture from sort of senile osteoporotic fractures. But one of the things that needs to be understood is that most compression fractures in patients with myeloma are more of the latter. They're osteoporotic fractures rather than plasmacytomatous fractures. So only about 25% of compression fractures in patients with multiple myeloma actually look like this versus like this. And we can look at those differences in the pattern of myelomatous involvement. So patients who have basically normal MRI patterns versus patients with focal disease versus patients with this diffuse or what is abbreviated here as salt and pepper pattern, but what we also call variegated patterns. So this level of marrow involvement by MRI has both diagnostic and prognostic significance. We can also look at the combination of focality and diffuseness, and we can break, this is database from Arkansas, and you can see that the level of myelomatous involvement in the newly diagnosed patients correlates ultimately with outcome, and perhaps not surprisingly, there is a similar correlation with the persistence of those kinds of abnormalities at the time that patients go to transplant. So these kinds of tools are very important, both as diagnostic elements, but also as ways to predict ultimate outcome for patients with multiple myeloma. The group in Arkansas has been very diligent in terms of evaluating the number of focal lesions, and those patients with larger numbers of focal lesions certainly do worse than those with less, and the disappearance of those focal lesions post-transplant also correlates with response. So the modality that we have begun to use, because it combines a number of interesting variables, and that's PET-CT. The CT part of the PET is identical to the low-dose whole-body CT that we've been talking about, but the PET scan also gives us some metabolic information that you can see here. Now, the problem is, how do we declare a lesion as being positive or negative? So the lymphoma doctors have made some effort to do that, and the myeloma world has to some extent adopted those same kind of criteria, but there is certainly no standardization yet available. So when we compare PET-CT versus MRI, we see that there are lesions that are picked up by PET that are not picked up by MRI, and that there are lesions picked up by MRI that are not picked up by PET. So we remain with modalities, none of which are perfect at this time. And we can use the combination of clinical response and radiographic response to stratify patients as they proceed through their therapy. So the combination of either PET and clinical evaluation can break patients up into groups with distinctly different differences. There is also a correlation between the degree of metabolic activity in the PET lesions and the ultimate outcome. Patients with more metabolically active myeloma do worse in the end. This can be used as a criteria that has a significant prognostic evaluation, as you can see here in data from the group in Arkansas. So in conclusion, we need to move away from skeletal surveys. These are both not sensitive and not specific. Whole body CT certainly is a much improved modality over skeletal survey. The role of MRI is a controversial one. It is not routinely available throughout the world. This is not a standard MRI. If you're going to do a whole body MRI, you need a special coil, and most radiographic centers in the United States do not have the capacity to do that kind of testing. So it is a very specialized test. So to to restate this, we need to explore the role of these things. And I will just go through this very quickly because I apologize for speaking for such a long time. But many of you will know that there is a large clinical trial going on in both the United States and in France called the IFM 2009. It's a cooperative study between the Dana-Farber Cancer Institute in the US and the IFM in France. But incorporated into that trial is a prospective evaluation of different radiographic modalities. And I will just show you this slide. And that in this large prospective study, that achieving radiographic negativity is as important a predictor of outcome as achieving biochemical negativity. And when those two things are overlaid on each other, we can see that this is a very powerful predictive of ultimate outcome. So, in conclusion, this large cooperative study shows that PET and MRI imaging contribute significantly to identifying subsets of patients that probably are deserving of additional therapy. So we take our biochemical profiles, we now look at MRD negativity, but we probably need to overrely on that radiographic negativity to actually identify patients who we should truly call complete remissions. So there are a number of still open issues on how to actually standardize this kind of therapy and where and who these therapies should be utilized, because they are very expensive kinds of testings to do. So I thank you very much.
Thanks, Professor.